Good morning. As soon as you get in, just type here in the chat. Thank you. Good morning, guys.
Good morning.
Everyone's here. Good. Let me work on pulling up my other PowerPoint. I left off at. Okay. Okay, everybody's getting in. That's good. If you're just getting in, just type here and we'll get started here in a second. Give everybody time to get in the chat. Okay. Okay. I am doing well this morning. I hope you guys are all doing okay. Somebody's home. Someone's here. Okay. Okay. We're almost all here. Let me just give people a few more minutes. Found a video that we'll share. So yes, besides my computer crapping out on me last night, which was, I've been having computer issues. So I don't know, maybe all that wind, my Wi-Fi was really spotty. So it was a lot of fun. Okay, hopefully your other classes are going okay. Doing okay. I still haven't heard an ETA for when we get back. So stay tuned on that. Yes. Okay. All right, we're almost all here. Is there any questions or concerns right off the bat that anybody has? Still working on my videos and hope to get those. Yes, our home computer, my husband's been trying to rebuild, and internet, it's just been kind of a nightmare. So at least I have this in the morning and I can get this going. I will be going through and logging the first homework. Hopefully you're working on the second homework. And again, I think today I just want to finish the little bit of the hip dysplasia. I'm going to show a video, and then we'll start on the Stifle. So like I said, you should have received all those PowerPoints already, but yes, I will. I don't have the homework pulled up in front of me. Caitlin asked a question about the homework. So yeah, I can try and pull that up. I have several screens pulled up, but let me, since you have a question on the OFA, again, if you're just joining, please type here People are still kind of coming in. But if I go, let me do my screen share here. And hopefully you can all see this. Let me, again, I'm going to just mute everybody, but just type a question if you have it. And let me move this over here. Okay. So the question was, go back over the OFA and pen hip. Okay. So the basic thing here is OFA and pen hip basically are two ways to get your dog certified hip dysplasia free. Now, typically, if you just want to check your dog and find out if your dog has hip dysplasia, they'll do OFA style radiographs. OFA is the gold standard. It's been around a lot longer. The key here is, and again, Caitlin, I don't have the questions in front of me, so you may want to type the question or unmute yourself, but let me explain briefly what I'm talking about. Is they have to be 2 years old for an OFA. So they have to be, they're not going to certify a dog at 18 months old. This is probably, and okay, thanks, Caitlin. I'm getting into FHO here next. That's one of the next things I was going to talk about was the FHO. And I'm going to get into who are candidates. So we haven't talked about that yet. It's in the notes, but I'm going to talk about that next. And I'm going to show you ortolani, and I'll talk about cranial drawer. So that's coming up. But OFA, they have to be typically sedated, good. They have to be identified because the radiographs have to have the name, the client, the date. So the radiograph has to be labeled correctly, 2 years old and sedated. Once your dog is OFA certified, it's typically when people are using them for breeding. So the requirements, OFA certification is basically saying that they're hip dysplasia free. So you're certifying that the dog you're breeding does not have hip dysplasia. That's what OFA is telling you. It's the Orthopedic Foundation for Animals. You'll send the x-rays. They will confirm there's no hip dysplasia. They'll give your dog a registry number, and then you basically can breed 2 dogs that are OFA certified. The puppies should not have hip dysplasia. It is not 100%. And the requirements are that they have to be 2 years old. Okay. Pen hip is another type of certification, but you can do pen hip radiographs as early as 16 weeks. So pen hip does not require them to be 2 years of age. The thing that pen hip does is there's a bracket that goes between their legs when you take the x-rays. So it's a specific type of bracket so that it basically distracts the hips and it can compress the hips. So they do a distraction and a compression view, which is a little different than the OFA. But I'm going to tell you, your doctor has to be pen hip certified. So not every doctor can do a pen hip radiograph. Okay, so the doctor has to go through a certification, and then they can say they are pen hip certified. They can do pen hip radiographs. Okay, so the difference is the age and also the doctor's certification. Both of these types of certifications are basically to say that the dog does not have hip dysplasia. But most of the time they're doing this because they're breeding. Okay. So that should answer the questions there. Let me go to one thing I wanted to mention yesterday that I did not, some people were still on the call with me. When we do non-steroidal That is for pain. They're an anti-inflammatory. And when you have joint inflammation and arthritis, there is inflammation in the joint. Non-steroidal anti-inflammatories basically will be given, and most of these dogs, as long as they can tolerate the liver and kidneys and there's no nausea, I mean, I've known of dogs that have been on these drugs 2 and 3 years, and these are given. But these start working within a day or two. When you give non-steroidals, the dog should get some relief after a couple doses, or at least a couple days. The difference with Cosequin or any of the glucosamine chondroitin, again, an owner can just go to Costco, Walgreens, Walmart, and get the same glucosamine chondroitin that we would take. As long as, the doctor will give them a dose, and they can get generic human glucosamine and chondroitin. They don't have to buy Cosequin, but those drugs have to be given for about 4 to 6 months before you see an effect. So these are not a quick, oh, my dog is painful. This is going to take time to rebuild that cartilage. And again, these are going to be lifelong drugs. It's not like the question I get from owners is they'll give 2 days of Cosequin and they're like, he still hurts. He doesn't want to go upstairs. It's like, it's not a pain medication. Cosequin or the glucosamine and chondroitin is rebuilding the cartilage. It's rebuilding, some of those tissues to help the joint. So that's more of a long-term goal. And you need to do this for at least 6 months. Maybe 4 months, you're going to start to see something. And the thing is basically, you want to let owners know this because they're going to think this drug is just a quick fix. And the doctor may not explain that to them. So usually it's the technician's job to say, so I tell owners, give it continuously. It will take time. In the short term, we can do things like the non-steroidals. In really bad cases, we can get into tramadol or gabapentin. So we can add drugs to in the short term for that more painful, but Cosequin is going to be a long-term medication. And you can give these nutraceuticals with non-steroidals, with tramadol. So a lot of times they're getting these drugs with other medications. And that should be fine as long as you don't see nausea. But I'm telling you, if a dog is on Rimadyl, Cosequin, tramadol, and they start vomiting, we're stopping the Rimadyl. That's probably the offending drug of those 3. So most of the time, these nutraceuticals could potentially cause a little bit of soft stool, but in general, they don't have too many side effects, okay? But if you're giving Rimadyl, what we'll usually do is we'll take away the Rimadyl, and then we'll give the other drugs. And if the vomiting stops, it was probably the Rimadyl. If you take away Rimadyl and you keep giving the other drugs and they're still vomiting, well, then maybe there's a sensitivity to glucosamine or chondroitin. You always could have that sensitive dog that is going to, tolerate, not tolerate certain medications, okay? So hopefully you understand why we're giving the different medications, what is their role, okay? Because it's your job to explain to the client what these medications are for. A lot of times they ask the tech. So hopefully everybody understands. And I already talked about Adequin. Now, all of what I just talked about, weight loss, medication is all kind of, non-surgical interventions. Those are things that everybody can do to make their dog feel better. When we get into severe cases of hip dysplasia, there are surgical options. One of the first ones is an FHO. It's called a femoral head and neck osteectomy. And ectomy is removal. What you're literally doing, okay, I don't know if you can see in this picture because it's not the greatest picture, is here they have cut off the head of the femur. Okay, so here's the acetabulum. If you've got the head of the femur and it's doing this, the doctor can literally cut and remove the head of the femur. Then you're just going to have this and then the shaft of the femur. And what this does is it forms scar tissue and it creates what's called a false joint. So technically, scar tissue will help hold that leg together. And what you're doing is a lot of the pain and severe hip dysplasia comes from the rubbing of the head of the femur in that joint. So if we take off the head, the goal is hopefully we will reduce the pain of that dog. Hopefully everybody can understand, if you don't have the head of the femur doing this, well, there's going to be a big source of pain, and it reduces the bone-on-bone contact. But the key here, and maybe this will answer the question on the homework, is this is dogs that are 40 pounds and under. And I will tell you, it's rare. Cats can get hip dysplasia. Maybe usually seen in like bigger cats. But a cat can have hip dysplasia, and you can do an FHO on a cat. When we call this a salvage procedure, it's basically like, this animal is not getting relief. What else can we do? It's not permanently fixed. And the other thing I will mention, when you take away the head of the femur, are they still loose walking? Yes. Now the issue, Michaela, I'm glad you brought that up, because the issue with this dog is now you do not have the head of the femur. And so, yes, you do not have the stability in that leg. The problem is this dog was probably not putting weight on that leg anyway. A lot of these dogs compensate. They come in bunny hopping, or that leg is atrophied. So by taking the head of the femur, we're not changing a whole lot of how they walk. We're just taking away some pain. So, if you do it, they're usually not you're going to take away their pain. They may actually feel better. They're not going to potentially walk a lot better, but they're not going to hurt as much. So it's when we say it's salvage, and an FHO, cost-wise, we're probably talking $1,500 or less, depending on the clinic that you get it done. So an FHO is not expensive. You're literally just cutting off a chunk of bone. So surgery-wise, it's not complicated. You don't even really have to have an orthopedic surgeon to do this. A lot of regular vets can do an FHO. You're good, Liz. So one thing I will say, but the key is you have a 100-pound Labrador or an 80-pound Golden Retriever, they are too heavy for this procedure, okay? If they weigh that much, because a lot of those 40-pound underdogs, you'll see they shift their weight to their front limbs, and they can kind of compensate. But when you get into the bigger dogs, German Shepherds, Golden Retrievers, it's going to be a lot more difficult for them to compensate with an FHO, okay? So this is more of a salvage, and literally you can see in this picture, sorry it's fuzzy, they've literally just taken off the head of the femur, okay? And then all of this will scar together. Again, it's not going to be super tight, but scar tissue is going to help hold it together. So it's not like the leg is like flopping in the wind. It's going to be semi-connected, but you're taking away the source of pain. Okay, that's the goal. Now, if we want to get into the bigger dog, okay, Chanel, that you had issues. I'm glad you're here. You can do something called a triple pelvic osteotomy. Now, an otomy is to cut into, not removal. Ectomy is removal. Otomy is incision. Triple pelvic osteotomy is called a TPO. TPO. This is typically done in the younger dogs that have severe hip dysplasia. We've diagnosed it. And they have not really had arthritis sit in. This is not a surgery you want to do in an 8-10-year-old dog. Once they have arthritis, we don't have a ton of options, but if we can get to them beforehand, this dog would have a positive ortolani, which was where you can feel the hip pop. What they're going to do is they're going to make 3 incisions. So here's your acetabulum, here's your head of the femur. If the acetabulum is like this, they're going to cut the pelvis in 3 spots, and they're going to shift the pelvic rim so that the acetabulum covers the femur. That's the goal, is like if it's like this, you're going to cut it and then move it, and then it covers the head of the femur. You're going to rotate. It says rotation of dorsal acetabular rim. Here's the dorsal acetabulum. If I rotate it, now it covers the head of the femur. If you look in this picture, you can see where they've taken this and they've shifted it to cover. There's a series of plates. So here, if you look at this pelvis here, they cut here up at the ilium, down here at the pubic symphysis, down here at the ischium, and right here at the acetabulum. And what they're going to do is they're going to shift that acetabulum over to cover. When I was at Purdue, we did this surgery. Not a ton, but I did help in some TPOs. You can see right here in this figure where they're making the cuts, and you can see that these plates have shifted that acetabulum. In this x-ray, this is what the plates look like. So you can see this dog has had bilateral TPOs. Normally what we would do, I will tell you in surgery, we would do one hip, one side, and then potentially 12 to 16 weeks later, we could do the other side, because you have to let the one side heal. Now, I'm going to tell you this surgery. Now, I was at Purdue. It's been a long time since I've been there. This surgery was close to $3,000. I'm not even sure what it would cost now. This is an orthopedic surgeon. This is not you go to your everyday clinic. This has to be done at a referral center by an orthopedic surgeon. So again, it's not cheap, but this, yes, it is painful, Caitlin. And yet, again, that's bone healing. But again, the advantage is if it's a young dog, bone healing heals very quick. I mean, in probably 6 to 8 weeks, that plate is probably healed. Now, but we wait to make sure that there's no complications. We don't want to cut into the other hip before the first one is healed. So no arthritis for a TPO, has to be done in a younger patient, and this can be done in like German Shepherd, Golden Retrievers. This can be done in the bigger dogs, okay? If you want to go the extra mile, you can do, so they're rotating. They're basically, if this is the acetabulum, here's the end of the femur, you want coverage. The acetabulum's over here. They're going to cut the pelvis and rotate the acetabulum so it covers, so that femur can't do this. That's the goal. Okay, that was weird. A bunch of squiggles on my computer. Okay. So hopefully that answers your question, Kayla. If the owner wants to do the ultimate, you can get into a total hip replacement. We did these when I was at Purdue. But this was about $4,500 to $5,000. I'm sure it's up in the $6,000 to $7,000 range now. This is at an orthopedic surgeon. Not every surgeon does these. At Purdue, we only had one surgeon that did total hips, and we had 3 orthopedic surgeons. Only one did total hip replacements. So this again is not everybody does them. Yes, and Michaela, it's very similar. It's literally the same technique that they do in people. What they're going to do is basically, they're going to cut the femur, okay? They're gonna make an incision, they're gonna remove the head and that upper neck. Well, they're gonna cut off the head of the femur. They drill down into the femur and they put the stem and they put a new head and they cement the stem into the femur. Then they grind down the acetabulum and they put a new cup. It's lined with like a plastic, almost like a silicone. So they put a new acetabulum and they put a new head and a shaft into the shaft of the femur. And then that creates a new, so you have a femoral head, you have a femoral implant that goes in the femur, and then you have a new acetabular cup. So if we look here, it's hard to tell on this picture, but there is a new cup. They cement that into the acetabulum, and then this is a metal stem. It's coated with like a silicone, and then this is a new, and you can see this stem goes all the way into the femur, and it has to be cemented in. When we did this surgery at Purdue, everybody in there had double cap, double mask, double gloves. We had to clean out the room. We had to bleach the entire room the night before, put all the equipment in the room and seal it off. And people were not allowed to come in the OR. Basically, once you were in a total hip replacement, because they don't want the door opening, because if you get infection down into that femur, it can eat away at the femur. So that cement has to be very sterile. One of the really bad, the surgeon that did this surgery had a bad temper. He was drilling into the femur and he cracked the femur. The drill split the femur. So then we were doing a femoral fracture repair on top of putting in the implant. It was very, very long surgery. It's one of my nightmares. I'm gonna play a video that, let me see. Can you guys still see my desktop? Okay. I'm going to play a video that talks about that Ortolani sign. So hopefully this works. Okay.
Hip dysplasia essentially is a deformity of the hip joint.
Can you guys hear that? Do it like this because my chat screen went away. Okay, good.
It can lead on to degeneration of the joint, arthritis, inflammation, and pain. The vast majority of dogs acquire hip dysplasia likely as a result of an inherited factor, and that's combined with factors such as body weight, rate of growth, possibilities of trauma during development, and other factors such as their environment during development. And
I don't know if you just saw that dog going down the stairs, but the back legs were going together. It wasn't like he was going like till he got to the very end. That's the bunny hop that I was talking about. They'll take the back legs and move them together.
Other factors such as their environment play a role in this. We commonly see hip dysplasia in breeds such as Golden Retrievers, Labradors, Rottweilers, and the German Shepherd is probably the most common in our practice. Most owners are going to recognize some type of discomfort, often reluctance to play as a puppy. They're going to see perhaps a change in the way the hind limbs are being used. Often smaller dogs, younger dogs will bunny hop using both hind legs together to get around, or especially going upstairs. They may recognize pain when the dog first gets up after a period of rest. Or they may see early exhaustion compared to other dogs they've had experience with in the past.
Yeah, it's usually much worse in the morning and sometimes at night. Sometimes as they've walked around during the day, they kind of work it out. After that dog got up the stairs at bunny hopped, he kind of like, his one hip kind of went down. So it's like, you might see that pause after bunny hopping, but it's usually worse in the first in the morning, sometimes at night after they've been sleeping.
If owners feel that their dog is possibly suffering from hip dysplasia, the simplest, best solution would be to see their local vet to get first an examination and then quite possibly x-rays to follow. A veterinarian is going to examine a dog to determine if it has hip dysplasia. Some dogs can be examined awake. However, often it's useful to sedate the patient to determine whether the hips are lax.
Okay, I'm gonna rewind just this last part. I don't know if you could see, what he's doing is he has his hand on the hip and he's moving this and then he's pushing it up and you could see it pop. That's the positive Ortolani when that pop happens. So let me just go back a little and watch on that dog where you can see that pop happen.
Be examined awake. However, often it's useful to sedate the patient to determine whether the hips are lax.
Right there,
laxity is the key finding in dogs with hip dysplasia. There is a test for laxity we refer to as the Ortolani sign. And we can demonstrate that on this model. In the Ortolani sign, we push on the femur under sedation. The femoral head rises out of the joint, the acetabulum. We lift the leg up and it clicks back in. And we're feeling for that click back in to tell us that the hip was actually out. If we confirm this, this is hip dysplasia, regardless of what we see on an X-ray.
As always, it is best to discuss with your veterinary.
Okay, so hopefully you could see they did it in lateral recumbency and then when the dog was sedated. And like the doctor said, some dogs, if you have a really good dog, you could possibly do that awake, but more often than not, you want to give sedation so that those muscles around the hips are relaxed. You're going to get a much better orthopedic exam with sedation. So most of the time when we quote for that, we quote for sedation in the protocol for hip rads and whatnot. So are there any questions on the hip rads? This last slide on your PowerPoint here has some links about Adequin, the Pen Hip model, the OFA site, the Pen Hip site. The last website on this slide is called acvs.org. That is the American College of Veterinary Surgeons. If you go to that website, it has a lot of client information about stifle surgery, hip surgery. It goes through a lot of surgeries and has a lot of good information on that site. So if you can get into any of these websites, it will be helpful. Okay, I'm going to close the hip one and I'm going to open the Stifle lecture now. You can always type a question. Hopefully everybody can see this new PowerPoint, but this was the one called the Stifle. All right, I'm just going to go with this one. If you have questions, pop in. But the next, probably most common issue we see are stifle issues. This could be patella luxations, but cruciate ligament ruptures. I mean, at VCA and when I was at Northwood and I helped in surgery, we would sometimes do 8 to 10 cruciate surgeries a week. So it's a very common occurrence. Understanding the anatomy of the stifle. If we look at this picture, number 2 here is the femur, 11 here is the tibia. So the femur is the proximal bone, the distal bone is the tibia. Now the fibula is behind the tibia, but the primary bone that we think of as the stifle is the femur and the tibia. Now, there is a series of ligaments that hold. Remember, tendon is muscle to bone, ligament is bone to bone. If we look in the middle here, the number 5 is that, we go over here, it's the lateral or anterior cruciate ligament. Some people call it the medial, but it is really the anterior cruciate ligament or an ACL. So if we say someone tore their ACL, and this happens in athletes and people, if you tear your ACL, that means that your femur can now come forward. So if you think about it, this is the ligament that prevents it from moving anteriorly or forward, okay, that way. Now, there are lateral ligaments. If you look at number 4 and number 6, you have a 6 as a medial, 4 as a lateral. Those are preventing it from going sideways or lateral or medial. Now, in a really severe injury, you can tear the medial, lateral, and anterior. If they all tear, well, that's getting extreme, but you see what I'm talking about. It could move any direction. The most common thing that we see is this forward tear. If you think about a dog jumping off a deck or stepping forward and tearing that, sometimes you'll notice the dog does something, moves forward, all of a sudden they jump up and they hold their leg up. And quite often it is a cruciate ligament tear. If one minute they were running fine and the next minute they can't put weight on their leg, that's potentially an issue. So if we look at this picture, number 8, what I want to mention here, there's a lateral and an anterior view. 8 is the patella. Underneath is that little sesamoid bone. That round bone is the patella. It fits, there's a groove in the femur, okay? When the knee bends, that bone, that patella should slide in that groove, and it should be seated. It shouldn't move sideways, and it really is just going to be seated well. So basically, if you have a good sound stifle, we don't have lateral anterior movements, and the patella slides nicely in that groove. One thing I want to mention is number 10 is the tendon for the quadriceps. If this is the femur, the muscles on the anterior portion of the femur are called the quadriceps, which are 4 muscle bellies. They come together into that tendon. So the quadriceps tendon is very important for holding that patella. And as we move down, it is now number 9 is the patellar ligament. But it starts up here with the quadriceps tendon, the patella is under there, and then you go down here to the patellar ligament. My knee, not TMI, but sometimes hurts when I go down the stairs. Like I get a little pain. And when I talked to the doctor and looked it up, she's like, you probably have patellar tendonitis. So I have a little inflammation of that tendon, but it's worse when I go down the stairs because my knee is pushing forward on that tendon, okay? Now, tearing a tendon on the outside here is gonna be kind of a different story. When I'm going to talk about in cruciate ruptures, we're talking about these internal, these are ligaments, and a ligament is stronger than a tendon. I mean, they're both very similar structure and different. So Haley asked, what are your thoughts on a partially torn ACL in regards of surgery? If you have a partial tear, so sometimes, and sometimes dogs don't fully tear it, the doctor will determine that on an exam, how much drawer, they call it drawer, is the doctor will try to push the bones forward and backwards. If they move and you have a lot of drawer, it means there's probably a full rupture. A lot of times, Haley and those dogs, they may recommend weight loss, physical therapy, pain medication, and definitely a lot of people do what's called medical management or non-surgery for partial tears. I think it just depends on your dog, their activity level, and how much pain they're in. Yeah, if your dog is doing medical management and is able to move around, now, and I don't know how old is your dog, if I can ask. Yeah, a 9 to 10-year-old dog, and again, if they're not super active, and if they're not super painful, cattle dog mix, okay, you know, a lot of times, as long as they stay fairly active, they can somewhat weight bear and they don't seem painful. You don't have to always do surgery. A complete tear, they're going to get a lot of movement and they are going to create a lot of potential arthritis. The bigger the tear, the more the movement, the worse the arthritis gets. And then the arthritis causes a lot of pain and inflammation. So definitely partial tears. I'm glad you brought up partial tears because it doesn't always have to be full tear to, you know, again, and these pictures, there's slight fuzziness, but the other thing I want to mention, if you look in the middle here, there's a little like pad. It's called the meniscus. Think of it like a shock absorber. If you have your 2 bones together, there is a pad of tissue, pad of cartilage called the meniscus, and it's kind of like a shock absorber. When a dog tears their ligament, okay, if they smush, I'm gonna get very technical, smush. If they smush the stifle, sometimes they're gonna tear part of that meniscus. If you get a meniscus tear, then it acts like a little flap of tissue, and every time they move their knee, that little flap of tissue gets stuck. And that can cause inflammation. So a lot of times when we do surgery for an ACL, we'll go in and cut out some of that meniscus. My daughter had a meniscal tear in her knee. She did not rupture a cruciate ligament, but she had to have surgery to go in, and she had a lot of, like, her knee was really swollen. She could barely bend it. They went in with an arthroscope and they basically sewed her meniscus back together, and knock on wood, she's doing fine. So, and people can get meniscal tears. If you have a meniscus tear, it doesn't mean that it just meant that there was maybe some compression and it tore a little bit of this little pad. And again, just think of it like like a tag. You know, sometimes you got an annoying tag on your shirt and it's always rubbing and causing issues. It's kind of like that, except in the stifle, it causes inflammation and fluid. If you get inflammation in a joint, it dilutes out the viscosity of the fluid, and then it becomes like if your grandma says, I got water on my knee. Well, her knee is probably swollen because she has arthritis, and it makes the fluid in the knee more watery. So if humans or older people say, I got water on the knee, it just means that they have arthritis, there's inflammation, and it waters down that fluid that's supposed to be really sticky and lubricating. So again, you'll want to refer back to these pictures when we talk about issues. But basically, the cranial and caudal ligaments are what stabilize. So you've got a cranial one. There is also a caudal one. But because, think about the motion, the going backwards motion doesn't happen as much as the forward motion. So the anterior tear, the cranial ligament, is more common than tearing the caudal ligament. So that's why we see most issues. So the cranial cruciate ligament tear is the most common. It's the main reason we see DJD. And DJD, if you remember from yesterday, is degenerative joint disease. I'll type it again just in case anybody missed it. Hang on one. Okay, and that's the main reason. A lot of reasons this happens. It tends to happen in older dogs. It can happen when they're young, especially if they're overweight. They have a higher chance. If they have like a trauma. Now, a trauma, we always think of like hit by car, but it could be they stepped in a hole in the backyard, or they were chasing a ball and they went to change directions, and possibly I've heard of a couple clients saying, well, I threw the ball and he ran and turned, and then all of a sudden he came back lame. So this can happen again. Like I said, they were playing, they were very excited. Sometimes the tibial plateau. So this tibia has an angle to it. Depending on how the bone formed, it may be at an angle that puts more pressure on that ligament. So sometimes it's geometry. And that is genetic, okay? That is the angle of the bone they were born with. So these are all reasons that they can get this. It can be hyperextended when they're, like I said, they went to jump off the deck and they moved their knee a wrong way. Obviously, trauma, they can rupture a ligament if they're hit by a car. Don't always have to be a fracture. But a lot of times if they've ruptured one ligament, they have a higher incidence that they will rupture the other ligament within a year. My neighbor's Malamute had to have a surgery, and within 8 months tore the other cruciate ligament and had to have the surgery on the other stifle. Those were complete tears, okay? And the dog she was about 3 years old. So, most of the time, not always, they will have an injury to that meniscus. So that little shock absorbing pad, a lot of times when they tear, they're going to have some tearing. And usually if you're going to go in and fix the joint, you need to fix the meniscus, because the meniscus will be, and that's usually just cutting away some of that tissue, because the meniscus doesn't like to grow back together. There's not a lot of blood supply to the meniscus. So a lot of times, so the reason, Caitlin, they end up tearing the other, Usually most of it's genetic. If they had an anatomical reason they tore one, they usually means the anatomy of the other stifles can be more prone to tearing. It can also be that they shift more weight to the other leg and they're using the other leg more. Yes, so Haley's putting, it can be from compensation. So normally when we go to fix one cruciate, they're always going to take x-rays and look at the other leg and make sure the other leg is healthy. But it can be from compensation. A lot of the times it's just genetic. They were prone to tearing the one. It puts them at a higher risk of tearing the other. And not always, but I've seen a lot come in when we already did surgery on the one like a year ago, and we're like, oh, you're back. So I don't want to say always, but it can happen. Now, some of these are going to be classic signs, and I'm going to say a lot of the clinical signs is how bad is the tear. Like Haley, your dog with a partial tear, how did you know? Like, I don't know how you knew like your dog's was partially torn. We'll see if she responds. One thing is, okay. She jumps off the back deck and would limp after. Would she put weight on her leg? Because, okay, so one thing that is key is that there's the non-weight bearing. And if I ask you on a test, non-weight bearing is the key sign, like all of a sudden, or they do what's called toe touching, like I talked about yesterday. They either are completely standing like a flamingo, where they're holding their leg up and they don't put it down, or they try to put it down and they're like toe touching, okay? They're shifting and they don't want to put weight on their paw. That's the very classic, you know, if a dog comes in like this, we're like, cruciate. Not always, but that's one of the very classic presentations of a cruciate. There can be inflammation. A lot of times when we take x-rays for stifles, we're going to see one stifle looks a little more swollen than the other, and that's because of the joint fluid, because of the inflammation. A partial tear is usually the dog is lame at certain times. So intermittently is toe touching, but then when the dog is inside, laying around, it's not as severe. So it's worse when they go out to walk. It's worse when they go to play. And then when they come in, they have periods of comfort or, you know, periods, but then there's times when they don't want to do anything. So it really depends on what clinical signs they're showing. So normally when we take the way we diagnose it, and just kind of like Haley said, you're going to take x-rays. They're always going to be better sedated. Most of these dogs don't like you pulling on their leg to take a good x-ray. So sedation, A, it makes the patient more comfortable, so they don't hurt when you're yanking on their leg. And B, you're going to get better x-rays because they're not moving, and you're going to get more relaxation of the muscles. So I'm always a fan. All of our orthopedic rads at Purdue were sedated. It was really not an option unless the dog was like an anesthetic nightmare. But most of the time, you know, the doctor's like, I need good x-rays if I'm going to go into surgery. So he wanted all sedated x-rays, and that's what we did. You're going to take a lateral stifle, and you're going to take an AP. And again, when you guys do your x-ray class or radiology 2, you're going to be taking these x-rays. So you're going to learn to take stifle rads, elbow rads, hip rads, shoulder rads, all these types of radiographs. Because as a tech, you're going to spend about half your day taking x-rays. So buckle up. Hopefully, you will, Caitlin. You will. It's going to happen. Don't worry, you have to do it. It's going to happen. So what we're looking for is any joint swelling, any arthritic changes. Now, again, if a dog just injures it that day, you're probably not going to see arthritis because it's an acute injury. But say we have a dog that tore it and the owner didn't do anything about it like 2 years ago. Well, say, Haley's obviously knows what to look for in her dog. But say someone goes, oh, he jumped off the deck and he pulled a muscle. Oh, he just hurt his leg. Oh, he'll be okay. You're always going to have those owners that something happened. Maybe the dog got better because it was a partial tear, but eventually arthritis is going to potentially start to happen. So you could take an x-ray and see some arthritic changes. That means the tear is probably older. It's not what we call acute. So you're going to get either people come in acutely, you're going to see some swelling, you're going to see some pain, but arthritic is usually the older injuries. You're going to palpate. And the thing that you're going to look is for what's called cranial drawer. When you palpate, if I ask you, what are you looking for on palpation, you're looking for cranial drawer. Now, let me go forward to this picture. So what you'll do is you'll have the dog in lateral recumbency. You guys can do this to your dogs at home. If they're super chilling on the couch, heck, you could probably do this to a cat. Don't get bit, but put your hand on their upper thigh, which is right in front of their femur, and you put your other hand below the stifle and try to move the two bones. What you're trying to do is go like this, okay? If you can move a bone, now Haley, maybe don't do it to your dog because I don't want to aggravate your dog's stifle. So Haley, don't do, well, you might feel something, but I don't want to aggravate your dog, okay? But if you move it, if you have cranial drawer, you can literally take that stifle and go forward, if that makes sense, okay? It goes more forward. Now, the degree of the tear is going to determine how much. Obviously, if it's a complete tear, you're going to get positive cranial drawer. It means you can move that cranially without movement. So this is what cranial drawer looks like. You literally move it back and forth. And again, those of us that have dogs that have a normal stifle at home, you shouldn't get a lot of movement. You should move it back and forth, and it really shouldn't do much. So here's a good picture. Here's the femur, the tibia. This is that tibial crest. That's the angle I was talking about. Depending on anatomy of your dog, the tibia is supposed to have a certain angle. And again, in genetics or how that bone formed, it may have a steeper angle, it may not be. The more angle you have here, the more tightness you're going to pull on that tendon, and that's going to create stability. So if we have it sharper, imagine if this is a really tight string. If it's like this, you're going to loosen up the pressure on that string, which is going to potentially change the stability. And like I said, the tibial plateau, your dog is born with that. So hopefully your dog has a nice tibial plateau that's normal. If we look at this picture, here is a ligament. Here's the anterior, or this cranial ligament here, and you can see where it's torn. So if you can imagine, this bone can move forward. That bone can go that way because this is not holding it together. Here's that nice little meniscal pad. So there's the meniscus. And again, a lot of times when they tear, they push a chunk of that meniscus off, and then it becomes a floating piece of tissue or a tear. That creates more inflammation. So the doctor is going to go in to do the surgery. Correct. The tighter the ligament, Miranda, the more stability you have in that stifle. Let me get to a better picture here. Now, this is obviously, this is it's a cranial stifle in a cat. Now, obviously, cats, we see this more in dogs, but say a cat jumped from, their little kitty tower or something, and the cat landed and pushed forward, you can see this stifle is supposed to be down here. This is in front of, this is the femur, this is the tibia. You got the fibula back there, but this is for, the patella is way up here. Patella should be right in this picture right here. But because, now this is a lateral view, you're looking at the sides, this is the anterior view. And you can see that it is not, things aren't where they're supposed to be. And so this is, and this was ruptured both collateral ligaments, so the lateral ligaments and the forward, everything is, so this knee is basically like, can do whatever, can move every which way. Okay, what I'm going to stop here is because now we're getting into treatment. So we're going to talk about the types of surgeries that you can do to fix the stifle. There's different types. Sometimes it's going to come down to size of dog, cost, because there is some, you know, I will say a cruciate ligament surgery, which is called a TPLO, we're going to get into. That's the newest surgery that you can do. Most surgeons do that. Is going to run about $3,300 to $3,500. Now, that is the gold standard treatment. That is going to fix that leg forever. Now, obviously, the dog can have problems later, would be rare. There could potentially be some arthritis, but pretty much when you do a TPLO, it's going to be fixed. There's other little bit cheaper options, but the problem is it's going to come down to size of patient. You're getting big on 100-pound Labradors. We don't have as many options as if we have a little 50-pound boxer, 60-pound, you know, beagle mix, cattle dog mix, you know. So again, some of our treatment options are going to depend on size of patient. Okay. So let me do this. Let me unmute everybody momentarily. Or obviously you can type something, you don't have to talk. Or you can just say good morning. Okay, well my plan will be to meet tomorrow at the same time. I'll get into the treatment plans. I'll get the homework looked at. I'm gonna get my computer to cooperate with me and work on those videos. And you are, as long as you've typed here, you are free to bop out. I'm gonna leave it open just for a few more minutes. I'm gonna mute everybody a sec because it's really loud. I'm getting, sorry, I was getting a lot of feedback. So if you don't have any other questions, you're free to bop off. Hopefully, Caitlin, I answered your questions related to the homework with the lecture. If not, okay, good deal. Glad that that's taken care of. Sorry, I saw your email. My computer's having issues. It was late at night. I figured I'd touch base with you this morning to get your homework. So I saw your email late. I apologize, I didn't email you last night, but glad we got that answered. Miranda asked, what's TPLO? Oh, well, I'll type it out. It's in the notes, but oh, hang on, I typed that to the wrong person. So Miranda, hopefully that answers. TPLO is triple pelvic, oh wait, TPLO. I'm sorry, triple pelvic osteotomy is TPO. I'm gonna talk about TPLO tomorrow, but TPLO, oh, hang on. So a TPLO is a tibial plateau leveling osteotomy. TPLO is for the stifle. TPO is triple pelvic osteotomy is for the hip. So they are different surgeries. It's just a difference in one letter. So we're going to talk about TPLO for the stifle. TPO is what we talked about for the hip when you change the angle of the acetabulum by cutting the pelvis. So hopefully, Miranda, that answers your question. Okay, thank you. Okay, again,